is over with, it's my great pleasure to introduce Annette Maruca from the University of Connecticut. And Dr. Maruca is an RN, um, um, an educator, and has done multiple seminars like this around wellness, for mostly for nurses, but for all allied health professions. She also is involved through the UConn with correctional systems, and is very familiar with what we're up against. Michael DiBernardi is also here. Michael is somebody that I've worked with in Wyoming, who's spoken at the ACCP conferences in the past as a keynote, and who runs the largest non-government. He is the CEO and a clinical psychologist at the largest non-government mental health agency in Santa Fe. These folks are very busy. They volunteered their time for this, and I applaud that, and I'm very grateful for having such talented people in this session. How many people actually saw the quality of life, the professional quality of life website, and tried to do the questionnaire there on the website? Will you indicate by just saying something in the chat section, or speak up if you wish, unmute and then remute if you actually did anything. I certainly did it. I found it was very useful as a person myself, as a retiree who's doing consulting work, and who is not seeing patients at this point on a formal basis, not prescribing medications, not seeing patients. I'm more of a consultant / medical director than a primary care physician at this point in my career. Found how interesting it was that I, of all people, as a retiree, could feel burnt out and tired, and even compassion fatigue, and I believe that the results were valid, as my wife frequently reminds me. I at the very end of this will repost the link. It's a very, very good tool. If any of you, and I know you are, I saw Johnny Wu earlier. I know many of you are in charge of correctional systems, oversee nurses, oversee mental health professionals, oversee medical providers, and these resources on the site, even if you don't take the 5-minute survey, the 10-minute survey, the resources on the site are just amazing and very, very helpful. So I'll say that, I see that only of the people in the room, I think about 5 have actually looked at it and completed the questionnaire, and I think that any of us who haven't done that are sort of missing out on something important. I'll just say that out loud. I'm trying to advance the slides. Michael, do you have any advice for me? Oh, I get it. It's at the bottom. Never mind. So our objectives, I'm not going to read to you. You can read. You've seen it, most of this, but I'm going to cover A and B. Michael is, Dr. DiBernardi is going to be covering C, and Dr. Maruca is going to be covering D. I think that, so I'm going to say something really important here. Under D, the American Academy of Family Physicians called me on that because the original objective was discuss how we can improve our personal lives and family lives through our way of coping with job stress. And they would not allow that objective. They would only allow the objective of discuss how we can improve patient care. But for me, I had no ethical qualms at all with just switching it to improve patient care, because if we're doing better, our patients are doing better. We're dealing with people who have experienced trauma of one sort or another in our correctional careers, and I thought it was a really interesting thing that they that was considered something we couldn't say we were improving our own lives. Only we were improving our patients' lives through the educational efforts. So what's the problem with corrections? Why are we at risk? I'm again not going to read this out loud. The patients are inmates. They're all convicted of crime. There's a higher percentage. It's been documented well that there's a higher percentage of what are otherwise known as difficult patients. The difficult patients and the difficult patient encounter is a whole nother seminar. But the bottom line is that we have difficult encounters on a regular basis with our patients. That's not to say that people in the community, certainly I've worked in the community, I had plenty of difficult encounters and difficult patients, but the bottom line in corrections is you've got somebody difficult or somebody who you're just not able to deal with, and you can just ask them to leave your practice, but certainly we cannot. It's a paramilitary environment, and that's difficult because our goals are different from the goals of the people who are the custody agents. And that's true whether we like it or not. It's just the way it is. It's a potentially violent environment. Sometimes there are negative cultures. They have nothing coming to them is something that I've heard way more than I ever want to. Our patients are sick. And don't have positive experiences with authorities, so therefore we are authorities. It all costs money, and we're trying to not spend it. We're trying to not break the bank of whatever jurisdiction we're working for, and it's valued to keep them inside. So we've got to take care of the patient needs, regardless of how skilled we might be. I'm opening it up for anybody have any other suggestions about why we might experience difficulties in corrections. You can unmute and speak up if you wish.
This is Charles. Hi, how you doing?
Hi, Charles.
One of the problems that we have as providers in a correctional center is that our patients don't listen to us and many times don't do what we recommend and prescribe. So it's very challenging to go through a workup, evaluate the patient, the physical, get tests, and then tell them what they need, and then they disregard it and do what they want to do anyway. So that's
you set them out. You set them up an outside appointment, and they refuse on the day of the appointment.
Yeah,
we've all had that happen to us. Yeah. Again, I think that's in the general population. That certainly happened to me in my private practice, but not to the degree that it happens in corrections. Somebody else?
Hey, Mike, this is Mary.
Yeah. Hi, Mary.
Hi, how you doing? I'm going to speak up because I know I got a meeting conflict. But I think that while we have one of the things that I think make it difficult, we have some people who are truly challenged, and I really appreciate challenging, and I appreciate you saying that even in the traditional healthcare setting, you have challenging patients. But one of the things I think we sometimes bring to the table or become comfortable with are biases, inherent biases about our patient population. I think that adds to the stress and the ethical conflicts and the moral challenges in working for our patient population. As a nurse, I was taught you take the patient where they are. That doesn't mean that the patient's going to always be my best patient in the way I see my patient or want my patient to be. But you have to start with them where they are. And when you think about the social determinants of health that impact our population, because all of them are not the folks who take out 9 people at a time and kill people and throw them in the woods. I mean, some of them are just substance abuse, mental health, general run of just doing the wrong thing. But they're not, your mass murderers. And yet we paint everybody the same way in our minds, some of us do. And then we share that as we bring on new people, which helps perpetuate that. And I'll stop. I think you get my point.
Yep.
Well, to tag on to what Mary's saying is just the stigma that's attached to that population. Mhm.
Sorry. But there are advantages. Our patients live at our place of work. They speak to one another after the visit. That can go against us, as Jeff Keller appropriately pointed out during the last session. If we're being jerks, they know it. They know it out in the wings. The nice thing is, I loved not having to talk to any insurance people and not having to deal with the insurance business. And yes, I had a medical director who questioned some of the things that I was doing, and we had a medical discussion about it and made decisions based on good medicine. I found the corrections environment a safe and secure environment. I found it a good environment to work in. I've worked in much more dangerous environments, and I think that our ER colleagues would go along with that. That the emergency room is certainly at least as dangerous as what we're dealing with. And I will say out loud that some of my patients were the most grateful patients I've ever worked with, because some patients expect nothing, and when you actually take care of them medically, they're very grateful. I promised that I would rush through my slides because we want to get to the meat of the presentation. I'm sure there are other advantages that we share, and I think that we need to emphasize the positive in our work environment. I'm just going to breeze through cases, and we can discuss these as we go along or after them. But the first case I came up with was a 34-year-old man in for a chronic care visit. He's obese, he's glucose intolerant, he's hypertensive, and he says, "You always talk about what I need to do. What are you going to do?" And he's demanding, and mostly he doesn't want to hear about anything besides getting more comfort items like shoes and a more comfortable mattress. He's unwashed, he's odoriferous, he's loud, he's confrontational. You didn't sleep well last night, and your teenage kids are acting up at home. And you suspect some drug use in your home. So this patient affects us.
We'll share this with you. Here.
How does this person, and we'll get into this some more later, but how does this person make you feel? He makes me feel disgust, whether I like it or not. Somebody is not muted. I wish you would please mute. Case number 2 is a 40-year-old man. You treated him for a minor laceration after he punched out a window at the facility. You wondered why there was a window that he could be able to punch out, but there was. He presents, you're called emergently to cell side, and he presents with a deep laceration with bright red blood coming from his antecubital fossa. And people think it was self-inflicted. You talked to him about depression 2 weeks prior, and he seemed fine to you. And you asked all the right questions about depression on your last visit 3 weeks. Well, I said 3 weeks or 2 weeks before, but you didn't refer him back to the mental health provider because they were taking care of him. They were seeing him on a regular basis. You immediately responded to the pool scene. You found him with agonal respirations, lying in a pool of bright red blood, and he was essentially dead when you arrived. This actually happened to me. The nurses needed to convince me to stop CPR on this guy. I had to go home and take an hour bath. We couldn't get on IV access, and he was dead at the scene. And the third case, so I'm running right quick through these cases because I think that people in corrections will recognize these kinds of situations that we find ourselves in. The third one is a 46-year-old man. You're called to the scene in segregation by custody. Custody never called me, but the custody people actually called me on my desk phone and said, "This jerk is making him cellmate, carrying him to the toilet, and he's in segregation." You evaluate him thoroughly, you do a thorough neurological exam, you find nothing, and you schedule a follow-up in a week just in case you missed something on the first visit. And on the second visit, you find that this guy, look, he had clonus of both his lower extremities on the second visit. So you were like, wow, that wasn't there a week ago. What's going on here? And send him to the ER for an MRI, called the ER physician to make sure that he knew what you needed. And he's found to have a giant spinal tumor with Mets, and he's dead within 6 weeks. And this one also is from my personal cases. I'm open to comments, but I want to get on with the rest of the thing. I think that this is illustrative. B was consider cases that show what we're doing on a day-to-day basis in corrections. And I think that these cover things like vicarious trauma. I was certainly traumatized by trying to code a guy who was clearly already dead. I was young and idealistic and didn't think that anybody was ever going to die on my watch back when I was in my 30s. Certainly that was very much vicarious trauma. I called my wife and I told her to get the kids out of the way and to get me into the bathtub. And clearly it affected me because I'm still talking about it today. The third patient is about how the custody agents will tell us one thing, you know, this guy's being a jerk. He's making his cellmate carry him to the toilet. Well, that guy had a spinal tumor. You know, he was a sick man and he had a very rapidly progressing tumor. Any comments?
Yeah, I'll add a comment. I'm Ed Kern. I'm the director of psychiatry of the Alabama Department of Corrections. You know, I spent years working in consultation liaison psychiatry and in academic centers before doing this. And this case just strikes me as one where, you know, a collaboration between mental health and medical can be very helpful. As a psychiatrist doing consultation, you frequently do see cases where there won't be anything obvious medical, but initially, but then sometimes you look and you can't explain it psychiatrically. So you say, well, let's go back and take a fresh look. And, you know, I can think of cases, for example, where it turned out to be MS or something, but occasionally it does turn out to be malingering or catatonia or whatever. But anyway, I think the key concept to take away is just that collaboration I find to be refreshing. It helps me. It helps me to stay in my physician role, but also do more for the patient. So just wanted to throw that in.
Yeah, I totally agree with you. And actually the second case also demonstrates some of that, because I would have felt a little less guilty after talking with this guy about depression and thinking that he was that we didn't have an issue. Actually, by the way, the point of the case was that he had been planning for quite a while. He had saved that glass that he had punched out, and that's the instrument he used to commit suicide with, I think 2 or 3 weeks later. And so yeah, that collaboration is essential. And so I'm going to pass the discussion along to Michael. And I'm sure that I went over my 5 minutes, but oh well. And Michael, why don't you take this from here?
Thanks. I've worked with you long enough to know that times are just a suggestion, not a rule. So thanks for having me, everyone. So yeah, I'm a clinical psychologist. I run a community mental health center in Santa Fe. And just up front, let me say I am a born and bred cognitive behavior therapist. So the framework we're approaching this with is through cognitive behavior therapy, which hopefully most of you are familiar with to some degree. The instrument, and again, I want to emphasize that if you have not looked at the ProQoL instrument that we sent the link out to, really take a look at it. It's a great tool that I've used with my team for many years at different times to really just take a a snapshot in time of where everybody is in terms of the work we're doing, our professional quality of life. And so if you take the tool, it's a standardized instrument. A lot of research has been done on it. And there's a brand new, and we sent the link out to the newest one, which is for healthcare professionals. And so it's looking at professional quality of life, and it's seeing it as an outcome of different factors. So perceived support in the workplace, what you're getting from your colleagues, your superiors, your patients, compassion, satisfaction, how good it feels to do the job. And those are considered positive contributors to our professional quality of life. But then the negative things, and Dr. Perrine has touched on some of those: compassion fatigue. And I think we've all probably experienced that. At the end of the day, you go home and you're tired of giving, you're tired of taking care of other people, and would like someone to take care of you, even if it's only to draw a hot bath. What contributes to compassion fatigue are things like professional burnout, vicarious trauma, or secondary traumatic stress. And what's called, and this is a part of the new tool, moral distress, meaning being asked to do things that you don't necessarily agree with, but it's what the system is asking for. So when you do take this instrument, it's going to really, it's answering a few simple questions. It'll really break down and give you ideas of where you are on each of these scales. Maybe you're very high in vicarious trauma and burnout, but no moral distress. Maybe it's the opposite. But what's really nice about the people who put this instrument together is they have a lot of tools for dealing with this. And as we move forward tonight, Annette's going to talk about some different things that we can do to mediate the factors that are contributing to our burnout, our vicarious trauma, etc. But the website has a lot of really great downloads, worksheets, things that you can work on. And that's kind of what I want to focus on. Mary made a great comment about when we first presented these cases about bias. And that's really what this is about. So, I would ask, I'll put it out to the group right now, on any of these cases, what are your reactions to them? What kind of emotions come up when you hear about these? What kind of thoughts do you have? Anybody want to put anything in the chat about a reaction you might be having to one of these cases? All right, maybe nobody's reacting. That's good. That's great because
Hi, it's Michelle. I just don't type that fast.
okay.
See if I can get myself on video. Okay. Oh no, it didn't work. Okay, anyway. No, with the cases, I'm Michelle Staples Horn. I have juveniles, so it's a very different population. And I did look at the questions. I didn't really score myself, but I think I may have a higher satisfaction because I feel like there's always hope with kids. And the other way that I always look at any job that I do is I just ask myself, have I done the best that I could do under the circumstances? And that's really all you can do when you look at these other cases, and try not to second guess decisions that were made previously because you did the best you could under those particular circumstances.
Great, thank you for that. And that's a really important concept. Marsha Linehan, who developed dialectical behavior therapy, in talking about the patients we work with, said something that, what we need to keep in mind at all times is that everyone is doing the best that they can in a moment. Doesn't mean that we like what they're doing, doesn't mean it's the healthiest decision, the most appropriate decision, but they really are doing the best they can based on the experiences that have happened to them, what got them to that moment. And so I think, Mike, you moved out of the slides there somehow.
Whoops, sorry.
But I think that's an important concept to think about in terms of our biases, because we tend to go into situations with our own belief systems. And this is what the core of cognitive behavior therapy is about, is that situations happen, but it's really our beliefs about those situations. So you can go finish with this slide, Mike. The fundamental concept of all of this is that it's not facts that you can go ahead.
Excuse me.
There we go. Do the next one too, Mike. The next point, there we go. So it's not the facts that upset people. You know, these patients we're working with, these inmates we're working with, they are doing the best they can in the moment. Now, maybe the best they can is to be really difficult, really challenging, really problematic, but they are doing the best they can. And so if you are finding yourself upset by what somebody is saying or what somebody is doing or burnt out, hate to say it, but that's on you. That's not on them. And this is a challenge for a lot of us to adopt early on, because you know, we want to blame. When we talk to people, when you go home at the end of the day, you'll talk about, you know, this, as Mike said, it showed in the slide, you know, this was a jerk who's always pushing my buttons. He's, you know, attention seeking, he's malingering, these kind of things. Well, you know what? Those aren't the facts of the situation. Those are your interpretations of the facts about the situation. So I liked what Dr. Kern had to say about, you know, collaborating. And, you know, one form of collaboration is really reality testing. If you're having reactions to somebody, maybe it's a good idea to talk to someone else. And in all of your, not all these cases, but in these cases that Dr. Perini shared, you know, we may have an assumption about what's going on. This guy's just being a jerk, making his cellie carry him to the toilet. And we're responding to them in that way. We're treating them in that way. But really, this guy had a medical issue going on. That's why this was happening. So it's on us, if we're noticing that we're having reactions or we're feeling upset about what's going on, it's on us to take a look at what are our beliefs that we're telling ourselves about what's going on here, because that's all that we can change. You know, we come into this field thinking that in a lot of ways we can change other people, but in the end, we can't change anybody. The only person that we can change is ourselves. Now, we can help someone in their own journey of change, but if you're putting all of that on yourself and finding yourself frustrated because of your assumptions and beliefs about what's going on, you're just setting yourself up for these negative professional quality of life factors as you move forward. So it's not these facts that are upsetting you. It's not these difficult patients. It's not your colleagues. It's not the administration of the facility. It is you that is upsetting yourself by the beliefs you have about those things. Mike, let's move on to that next slide, please. So this is basic cognitive behavior therapy. But what I wanted to say was, and you can go through all of those points on this one, Mike, is that this is not a new idea. You know, traditional CBT started with Albert Ellis in the 50s, but these are ideas that have been around forever. So, you know, the first point was from the Buddha in the Buddhist scriptures: we are what we think. All that we are arises with our thoughts. With our thoughts, we make the world. The Bible says, you know, as I think in my heart, so am I. Epictetus, who is considered one of the Greek, you know, founders of kind of this mode of thinking, is men are not disturbed by things, but the views of which we take of those things. And similarly, Shakespeare there, nothing is either good or bad, but it's our thinking that makes it so. So all of these are just kind of a point to say that this is a framework that's been around for a long time, that if, you know, we're setting ourselves up for burnout, we're setting ourselves up for all kinds of negative reactions if we are thinking that, you know, people are doing things to us and it's up to us to fix them. All, again, that you can change is your own belief system. So it's a way of saying, if you're feeling a certain way, it's on you to look at what are your assumptions that you're carrying into this situation. What are you doing to make yourself feel a certain way? And therefore, what can you do to take yourself out of this mindset? Move on to that next slide, please, Mike. So one way to look at this is, you know, so with our sincere thoughts, beliefs, and attitudes, we can create, maintain, and eliminate all of our emotional feelings. So when I say sincere, it means things that you really believe. You may, you know, tell yourself or tell other people, I believe everybody's doing the best they can, but do you really believe that? Is that really what's going on with you? So when I'm saying sincere, it's, you know, you need to kind of step back and really take a look at what's going on with me here. because it's our beliefs that are creating our feelings, and it's our beliefs that are creating our behaviors according to this model. Now, I'm going through this very quickly. This is kind of what I teach my patients over the course of treatment, but I've also done lots of talks and work with different agencies on professional burnout and teaching them that, if you're feeling burnt out, it's on you. Some of you might be reacting to that right now. It's not on me. It's, it's the prison administration. It's the medical director. It's, the nurses who don't listen to what I want. It's the patients who don't do what I'm telling them to do. Yes, all those things may be real, but those aren't the things that are making you feel a certain way. What's making you feel that way is what you are telling yourself about those situations. Mike, you had your hand up. Yeah.
Doesn't that just increase our own stress by taking that on? Come on, Michael. I mean,
it does increase our own
you're
stress.
making me more stressful just hearing this, that it's all on me.
I'm not making you feel anything, Mike. It's your thoughts you're having about what I'm saying that is creating that stress for you. Okay. And it's like I said, when I'm first teaching a patient this, or I'm first teaching a professional this, we have a natural kind of pushback against that. What do you mean? I work in a horrible setting. This is the worst staff we've ever worked with, et cetera, et cetera, et cetera. But still, despite all of those things, it's on you. You're creating your emotions. So go to that next slide, Mike, and then let me just lay out this framework a little more. Those of you familiar with CBT, there's different variations on this, ABCs, ABCD. I like the ABCD because it makes a little more sense for some of my, no, go back.
I am so sorry.
That's all right.
Yeah.
So the ABC model says that, we have an activating event, meaning we have a situation. A patient comes into us and says X. We're going to skip B for a moment and go to C. Often we then think that we had a reaction to what they say. And again, especially when we're talking to someone else, that inmate came in and told me this, I got so pissed off when I said that, or I felt so hopeless, or I felt, whatever your emotion. And then D is the behavioral response, what you did. That's why I like the D, so I threw him out of the office, told him he couldn't come back until he's showing me that he's taking his medications. So that's how we usually talk about a situation. Something happens, it creates a reaction in us, and it creates a behavioral response in us. What we usually skip, and this is kind of the meat of what I'm trying to talk about here, is B, what happens in the beliefs. Situations happen. As the bumper sticker says, shit happens, okay? Our reactions are our choice, and those come through our beliefs, our attitudes, our assumptions, those kind of things. So that's really the things that we can target. So you may walk out of a situation feeling very angry. Is it going to help you if I say, quit feeling angry, feel happy? Probably not. You're not going to be able to do that. But if I say, can you take a look at your beliefs, and this is not something that happens in a moment, it happens over the course of time, that's what you can change to interrupt this entire cycle. Move on to that next slide, please, Mike. So, and what I'm saying here today is a 20-minute condensing of what I, usually do a 3-day workshop on. And so I was going to, I was going to tease a little bit that if you guys want more on this, I can, help us learn specific techniques, specific strategies for identifying our unhealthy beliefs, and strategies for changing those, but it's much more than we can cover. But this is a little teaser here. So this is something I teach my patients, that if you're identifying a belief that you are having in a situation, how do you know whether that's a healthy belief or an unhealthy belief? Albert Ellis called them rational versus irrational beliefs. However you want to look at it, I prefer healthy versus unhealthy because it has to do with our own health. So if we want to identify whether a belief is accurate, and sometimes they are accurate, sometimes that person is a jerk. Okay, they just are. But if you're, sincerely looking at your own beliefs, these are the kind of questions that you want to look at. Does maintaining this belief, is it based on obvious fact? Is it, a rule of nature that this guy is a jerk? Maybe, maybe not. Does having this belief protect my life? That might be a little extreme. Or my health. If every time I see this guy on my schedule for the day, I start to feel anxious, annoyed, upset? Is that protecting your health to go into that appointment seeing that? Is having that belief helping you achieve your short-term goals, your long-term goals? Is it helping you to resolve or avoid conflict with others? And is it helping the way we want to feel? There's a lot that we can do to work with our beliefs from this framework, but these are just some ways that you can start to look at things that if you are having a reaction to a colleague, a patient, a situation in your workplace, the first thing to do is ask yourself, what am I thinking about this situation or this person that's happening to me? And then start kind of asking yourself these questions. Does it help me to think that this guy's a jerk? Is that helping me feel the way I feel? Is it helping me avoid conflict, etc.? So yeah, I've kind of laid a lot on you today, but what I am saying is that if you're feeling burned out, if you're feeling vicarious trauma, sorry to say it, but that's on you, or at least the path out of that is on you. Yeah, horrible things happen to us and we're human and we react, but the way that we can move out of those reactions is by taking a look at what's going on inside of us and modifying our belief system, our assumptions based on that. I know that was a lot. Happy to talk more about this as we move forward, maybe do another webinar on this if it's something you're interested in. But fortunately, having said all of that, Annette has some really good strategies that we can do outside of analyzing our belief systems to help us take care of ourselves outside the workplace and then bring those healthier attitudes into the workplace. And I'm happy to take questions as we move forward, but
Annette, you'll need to unmute, please. There you go.
Yeah, I just saw it. Thank you. Just to tag along on what you were saying about CBT and really our belief systems, we role model a lot for our patients where we are. And so to go along with objective D, which is if we engage in self-care strategies and behaviors, we need to role model that as well. And I can say that thinking about the ABCs, Ds does really help us and engage some of our self-care activities that we need to do. Again, there's a lot that we have to look at, where we work, and especially for me, my background primarily is in mental health and substance abuse. So I really recognize the challenges with patients like that. And there's many of individuals that are patients in the correctional setting that struggle with mental health. And so we have to think about that. They're very challenging and they can be very draining. I mean, you have to pay attention to things that are not spoken. You have to look at assessments that you have to do. And so what happens to us? We get burned out. And to half the time I find that people don't even realize that they are burned out. Like, what are your own symptoms of being burned out? And so as I can't see the background, so I'm probably not paying attention to it very well, but our environment is something that we need to look at that will really just stress us out. If you can go to the next slide, please, Mike. Thank you. So these are some of the consequences of it. I mean, we talk about it a lot. When I did that ProQual, I was quite shocked that, well, no, I don't know why I would say quite shocked that I was, had compassion fatigue. We get in situations, I'm doing 2 full-time jobs, I'm doing 2 positions in one, and just can't imagine why I could possibly be burned out or depleted, or like, why can I not do that things? And as healthcare providers, we all believe that we can control everything, that we should be able to make an accurate assessment, that we need to be able to make the assessment precise at every single time, so that if anything goes wrong, why did that happen? And then it's trying to really quickly manage that. So I'm not positive that we all know exactly what we experience and why we feel stress. And when we do feel stress, do we pay attention to it? Do we ignore it? Again, you have to be able to recognize that, there are many things that we can do in the situation. We're in a position where day in and day out, we encounter challenges. And I was thinking about what you were saying earlier, Dr. Perini, where, you know, we're in an environment where we are expected to take care of patients. We have to provide the caring. But again, it's always that balance of caring versus custody. How do we balance that out? How do we get that balance? So it's not just in the workplace do we have to find that balance. We have to find a balance in our own life, the balance between like managing our work life and then managing our home life. Next slide, please. Thank you. So resilience, what is really that? That basically what we would talk with our patients about. And what I say, resilience is the ability to have enough strategies to be able to cope. So it's coping strategies to be able to manage your stressors and to be able to find a balance where you stay healthy and where you can move forward and you can rise above the situation. So can resilience be taught? Absolutely. I mean, can we learn strategies to be able to, you know, say that, okay, this is on me. How I think is how I'm going to behave, and then there's consequences for it. Is it on me? Yes, but do we have strategies to be able to manage that? Absolutely. If we go to the next slide, please.
Oops.
Okay. So when we look at this, you know, there are certain things that we can do to balance between compassion fatigue and compassion satisfaction. And really, what are the ways that we can manage to do that? And there's a lot of things that we can do for ourselves when we get there. So compassion fatigue, I was thinking about your case where, you know, that individual basically committed suicide and didn't live. So you wanted to go home and you just wanted to completely wash away that whole experience. Okay. It's really literally, I mean, if you think about it, you're just like washing away all of the emotions and the experience with it, you know.
Well,
and
I and my clothes were literally covered with blood as well. So it
Yeah.
was both figurative and literal. Yeah.
Yeah. Yeah. And you know, and then you sit there and you say, what could I have done? Did I do everything right? You know, so how do we take care of ourselves? Situations like that is really where, you know, debriefing and working together as a team. Like, really, how did you feel? How did the other person feel? Like, how are we going to work it? It's the people that are right in that situation and in that moment that really provide that support for each other, you know, and so that you can do some of that debriefing. It takes time. There's a lot of times in situations where I've had to get help and restrain people and try to keep everyone safe. And so you just deal with it. You do what you have to do. But that when you leave it, everybody goes their own way. You know, you know, this one goes here, the CO goes there, the doctor goes there, the nurse goes there. But there's not that collaboration of like, what did we do? And that social support. It's that kind of social support that we need to help and do with each other. Other things that we can do healthy and working relationships is taking time. And I think about the ABCs and like what we think, you know, if you go in a situation and you automatically think like, I know I'm going to ask for this, they're going to say this, and so this is going to be the reaction. So why bother? But I'm going to do it anyways. You're already frustrated before you go in. You already know and anticipate your reaction of what you're going to do. And now you're going to be angry. You know, and we all do that. We it's instinct to do that because the way our mind thinks. So, you know, when you're thinking about like how I think I'm going to behave, you can renew your thoughts. You absolutely can. So you can go in and change how you're going to think about a situation to say, you know, this is my instinct. This is what I normally would think, but let me be open and let me look at what these things and then be able to manage your own behavior. The thing is, when you're looking at self-care and you're looking at coping strategies, those are the things that you can control. And those are the things that you can change. And even if they seem simplistic as taking 10 deep breaths, they work. They really work. If it means getting up and taking 5 minutes to go and walk and think about something before you come back, they work. If you can go to the next slide, please. So in some of these strategies, and you know what, like I was talking to Lori previously and just saying, like, sometimes we have to learn to say no. All right. Now, again, no may not be in our control. You may say, no, you know what? I'm not going there. And they're like, yes, you have to go, or you have to stay, or you can't leave. But within that no, if you can't say no and the organization or the system doesn't allow you, you still have that ability to say, okay, I can't control that. I have to stay. I have to do this shift. I have to go see this patient. But you can control how you think about it, and you can control how you're going to react to the situation. So in essence, you're still basically setting boundaries, and you're still basically taking care of yourself. And that's really what's important. You know, there's other that kind of promoting a culture of wellness. I've done a lot with gratitude. And I know that everybody says, oh, that's just, you know, being thankful. But, you know, I've done like whiteboards where there's gratitude. I've done it where they've come in and there's a whiteboard, they walk in and they say, you know, I'm thankful today that I have somebody help. I'm thankful that you're here. You know, those get your mind and the way you start thinking about situations. It changes your whole viewpoint, and so you start to be thankful, you start to be grateful. Like, did you ever just say, you know, thank you to someone for just like, you know, I'm glad I'm working with you today, you know, I'm glad you're here to support me. I mean, there's a lot of things to be grateful for, and it does change your attitude. It really does. I actually did a study with nursing students, and with each module that we were going through and educating, I had them say something that they were grateful for in that model to tie in the content, to tie in their clinical experiences, to tie in the staff that they were working with, and the setting that they were working in. And you know, this is the students that came back and had just experienced isolation and just a lot of losses from COVID. And it changed. I could see the actual change, and in their just the way that they were working together and collaborating together, and just their whole experiences. So it does really help. The other things in promoting well-being is you know, just exercise. And I mean, these are all the things that you know to do, but I guess it's a matter of making them a priority and actually practicing them. It's like you have to practice every time you go in a situation to change how you view it, to change your behavioral response to it, and then you will begin to see a change. The other thing is work-life balances. You know, I can't stress that enough. And where I work and with students and with faculty and with just staff in the hospital, I really emphasize work-life balance. I have had to say to individuals, when you leave, you need to turn your laptop off. You need to get away from your emails. You need to go with that social support that you have and really embrace it, and really find that balance. As healthcare providers, I think we are the worst at doing that. We always feel like we are expected to give, we are expected to care. I mean, and we do, but we think the only way to demonstrate it is by doing more than the next person, or giving until we bleed out. I mean, to literally bleed out. And I mean, in the sense of just being so emotionally depleted that we become depersonalized. We shut down. We don't care anymore. I'll give you a brief situation that I had where it really did happen. And I was and I was in a behavioral health unit, and I was working with individual patients, and they were, you know, just this, it was a borderline personality disorder. And I was working with them for a very, very long time. And it was a lot of that manipulation going back and forth. And, you know, they love you, they hate you, they, you know, pull you in, they don't like, you know, so all of that going on. And then one night I was in charge, and there, you know, the staff nurse comes and says, oh, you know, so-and-so is hiding in the med closet. You know, I think they're going to hurt themselves. And I literally said, don't bother me unless you see blood. And that really like shocked me, because how could I say that? And that's when I realized, in all honesty, that I was completely depleted. I honestly was depersonalized. I in that moment, in that true moment, I was just like, I really shocked that I didn't care. So I knew I had to do something. I knew I had to take a break, and I did. I just, it's self-care. I took a break from that. I went to a medical floor. I stopped, and then came back when I was ready to be able to do that caring. So, you know, self-care is really, really important, and we have to do that, and we have to find that balance. The other thing is, you know, it's not just it's physical, but it's emotional. You got to do things that help you through this. I love laughing. I just like to be around people that enjoy laughing. And I have a colleague on, Lori, that whenever we get together, it's like before we ever do meetings or anything, we laugh a lot. It's very supportive. And also, you know, just obviously exercise, we do the best we can, but social support systems are really critical, and spiritual things that you can do. For a lot of individuals, it's meditation, it's, you know, being engaged in yoga, it is prayer, it is so many of those things. A compilation of all of them is really important for us to engage in. And again, system wise, what can we do system wise? Well, we can make changes. I mean, we can't, it may not happen overnight, but, you know, in implementing a wellness committee, to be able to engage faculty, and to engage staff, and to engage students, all in this wellness committee of really committing to doing activities that help us to cope, and to be able to have enough strategies to do that. Is anybody ever feeling blues of day? Absolutely. Seasonal affective disorder. No kidding. It was in the chat. You know, yes, it's hard. It's that change in daylight saving times is hard. So, well, I won't get into the lamps and the lamp treatment. That's a whole different thing. Let's go to the next slide, please.
Whoops. Boy, I really blew that. I don't know what
No,
happened there.
well, that was it. I guess
Oh,
I'm
sorry.
finished.
Well, that was
No,
your
don't
last
worry.
slide, but but-
Yes, is there too.
Do I have what?
we have slides. These slides are
Oh, for the pro qual?
yeah.
Yeah. So I guess, in other words, just to tie it all up, is that, you know, there's much that we can do to take care of ourselves. And I think, you know, if we just begin to commit to doing one small thing and sticking with that, I think then you'll see our just our behaviors change, and really being supportive with each other, and being kind towards each other, and really like trying to begin to engage in activities that would support each other. That's it, really. Go ahead, Mike.
I'd like to jump in on just a technique that we are all aware of, that we need to use more often when we're in a tight situation with a patient, and that is to just take a deep breath and say something along the lines of, "We're not getting anywhere today. You go back. We'll both calm down and come on back. I'll reschedule you tomorrow. Watch the call outs. I'll have you on my list tomorrow." Or if it's Wednesday, you know, you got to assure that there's no emergencies, and some people will create emergency right there, but it protects you and it protects your patient, because sooner or later, if they're either going to get violent with you, or you're going to have to write them up for their bad behavior. As much as, I mean, I don't think I wrote up people maybe once in 20 years, but nevertheless, people around me have intervened and written people up for their behavior in my office. It's like, we got to chill out here, the both of us, you know. And when it's not on one person, but that whole get out of the visit, I don't know if other people use that very often, but I certainly used it. I used it probably once a week. And that next visit, almost universally, was a very positive, useful visit. It was the weirdest, one of the weirdest phenomenon that I experienced in corrections. But they live there, so you know that they're gonna, you know, that you're available to them. There were lots of comments in the chat. Seasonal affective disorder. Yeah, and somebody commented that it really works, and I found it very useful for my purposes, as far as just managing myself and my patients, because I knew that. So there was no way, Michael, that I was gonna be, my emotions were somehow gonna be gone. That was not a possibility for me in that setting at that time, and so I went with plan B, you know, because I knew myself well enough to know that I could get out of my professional role and model bad behavior myself if this visit kept up. Anyway.
Yeah, well, thanks. And let me comment on that, Mike. So yeah, I laid out an ideal kind of framework for cognitive behavior therapy. Let me emphasize now, though, no one or very few people are going to, in a moment, be able to simply just change their thinking. Okay. This is something that you work on. This is something that you practice, and over time it becomes available to you. You know, when we were preparing for this talk, I mentioned to Mike and Annette that, you know, I was living in Chicago in the 90s when the Bulls were, you know, dominating everything. And I remember seeing an interview with Michael Jordan, and the interviewer asked him, you know, how do you get motivated to go to practice? You know, you're the best player that ever lived. Why would you even want to practice? And he said, well, it's valuable to me. I get to work with my teammates. You know, we get to work on plays, those kind of things. But he said, but the most important practice for me is every night before I go to sleep, I spend a half an hour mentally practicing. I think about, you know, we're down by 2, there's 3 seconds left, I'm taking the ball out. You know, I rehearse these scenarios so that then when I'm in the situation, I've been there before, even if only in my imagination. And actually, most research on this shows that mental rehearsal is as effective as actual physical rehearsal. So, you know, the techniques that we can learn and move going forward are things that we have to practice, but over time, they do become second nature. They do become available to you, and you will be able to, somewhere down the line, interrupt your thinking in the middle of a really stressful situation and change the entire outcome. In the meantime, removing yourself from the situation is a 100% appropriate reaction to that.
There have been lots of comments in the chat. I'm not going to repeat all of those. Those are available for people. Are there any other comments? We're pretty much close to wrapping this up. We're at exactly 1 hour. And then I have a couple of announcements.